And with that, I will introduce Dr. Litt. Dr. Jonathan Litt is a practicing neonatologist, and I'm sure many of you already know him well. Originally from Cleveland, he's a practicing neonatologist at Becker Children's Hospital and an associate professor of pediatrics at Stanford University. He holds an MD from Case. We are always very pleased to have Case graduates back. So thanks, Jonathan. And he also has a doctorate in social science research methods from Harvard T.H. Chan School of Public Health. Dr. Litt completed residency training in pediatrics at University of California, San Francisco, and subspecialty training in neonatal perinatal medicine at Boston Children's Hospital. With formal training in both social and behavioral sciences and health services research, his research program has two distinct, though closely related area of focus. The first is to understand pathways through which chronic health problems impact behavioral development and functional outcomes among preterm infants over the life course. And the second area is bringing health services research and improvement science approaches to studying the delivery of high risk infant follow up. His work leverages population health management, value based care, and equity focused quality improvement approaches to develop innovative models of post discharge care. And we are very thrilled to have you here. Over to you, Jonathan.
Well, thank you so much, Sam, for that wonderful, warm, and kind introduction. It's so wonderful to be here today with all of you. Let me share my screen and my slides here. And I will begin. Yes, as Sam said, I grew up in Shaker, went to Shaker schools, and came back from medical school at Case, and it really is just a wonderful place. Wonderful place to have studied and to trained, and I'm still very much in touch with a lot of the folks there, and it's just a wonderful to be invited back to speak. Today I'm going to share with you in the next 45 minutes or so what I call really this idea of from surviving to thriving, a life course health development approach to preterm infant follow up. And it really is trying to bring together those two sort of different avenues of scholarship that I have embarked upon, really sort of bringing social behavioral science theory and frameworks to sort of practical applications for health services research. So if you'll indulge me, this will be a little bit of theory, but then really trying to think about how do we apply it and translate it for improving infant follow-up for our smallest babies. I have no disclosures to make. So for the next bit of time, we will spend thinking about the following learning objectives. So first is to identify at least 3 limitations to current approach to clinical follow-up. So not research follow-up, but the clinical follow-up that we do for high-risk infants, particularly preterm infants after NICU discharge. The second is to describe key components of life course health development framework, so really bringing in that theory. And then applying life course health development concepts to addressing gaps in post-discharge follow-up care for preterm infants and their families. So first, I may not need to really spend too much time thinking about this background, but infants born preterm are vulnerable to adverse health and developmental outcomes. We know that there's a mortality risk associated with preterm birth, particularly at the earliest gestational ages. And on the right-hand panel, we see here different epochs of time of follow-up for infants born preterm. And we have seen improvements in morbidity-free survival over time, which is a good thing, but it's still not where we need to be by any means, particularly for those born at the earliest gestations. We've learned quite a lot over the past decades as preterm infants have survived into early adulthood and actually middle adulthood, recognizing that there are health risks related to preterm birth, sort of physical health risks that are outlined here on the left-hand panel, and on the right, developmental risks for language delays, motor delays, attention and executive function delays, and really how I got my start here in this whole area with the great Dr. Maureen Hack and Gary Taylor in an investigation when I was in medical school looking at learning disabilities in children who were born extremely low birth weight. Well, There are also some gaps in terms of the health services that we need to think about. This is a study that I did with a collaborative of follow-up programs in New England in collaboration with the Vermont Oxford Network, looking at children who were born under 28 weeks gestation at 2 years of age and looking at their follow-up. Unfortunately, only half of the eligible infants were followed up, but what I'd like to highlight here is that the amount of supports, medical and therapeutic and developmental supports that children required after discharge was quite high. 85% of these children needed any kinds of supports. Much of it had to do with oral feeding support. Many went home on oxygen, and many had need for physical therapy and occupational therapy. Children born low birth weight and preterm also are at high risk for rehospitalization after discharge, nearly a third in this sample, and many needed surgical procedures after going home from the NICU. So with this as a backdrop, understanding this epidemiology of preterm birth and what happens after children leave the NICU, the AP put out a statement many years ago and have updated it at least twice, recommending that infants with these kinds of risks have appropriate follow-up. And here, they really are rather agnostic about where this follow-up happens and who provides it. And it says that primary care physician with appropriate skills, or the pediatric medical subspecialist, or clinical personnel may provide longitudinal developmental follow-up when need for an input from multiple disciplines. You can have a clinic that provides multidisciplinary care, and it usually happens in an academic or a tertiary center. I'll spend the next few slides talking about how this has really panned out since this 2004 statement, at least, has come out in terms of this health service of clinical high-risk infant or preterm infant follow-up. So the family, I see. Sorry, my animation is a little off. So I will say the first thing I'd like to talk about is the family-centered medical home, and that is the gold standard for pediatric primary care for at least the last 4 decades. And it's composed of 5 different components. The first is that you have to have a personal doctor or nurse, someone that you can name, that is my child's caregiver. There needs to be a usual source of both sick and well child care. The third is there needs to be access to needed referrals. The fourth is effective care coordination. And the fifth is some element of family-centeredness. And this is defined as shared decision-making, cultural competence, and satisfaction with communication. On the right-hand side, I share just a little bit of information about what we know about care in a family-centered medical home. And we know that it's related to improved access to services, greater family satisfaction with care, and lower overall health care costs for children. Unfortunately, for preterm infants, these children, though they have higher need with having high rates of special health care needs, they actually are less likely than their term-born peers to have care in a family-centered medical home, as demonstrated in a paper we wrote many years ago using data from the National Survey of Children's Health. We also went on noted that having care coordination, particularly in a family-centered medical home model, actually was related to improved functional outcomes for children with special healthcare needs who actually had functional disabilities. So despite the fact that medical homes seem to be important places for care, and certainly for follow-up care for children who are born early, our patients aren't accessing that type of care. This I like to share when giving any talk about the health services landscape for our preterm and high-risk infants after they leave the NICU. It's actually a care map that a parent put together now over a decade ago, but I think it really illustrates what our families encounter when they leave the hospital, right? So you have the family in the middle with their child at the very center, and all of these are different sectors. All of these different colors represent different sectors or segments of where families get either care or services or sources of support. And you'll note, I think, in this very busy graphic that the lower left-hand quadrant is health, right? That's just one quadrant. And that, of course, is very busy, right? There's so many things going on in terms of the healthcare they need. But then you see there are all these other places, all these other sectors, places in the community that families are looking to, right? Schools, other kinds of support, legal and financial resources, and so on. The landscape is really busy and fragmented and really difficult to navigate. So, noting that the family-centered medical home really hasn't been the model to deliver the needed follow-up care, despite the AAP sort of recommendation that maybe the primary care pediatrician should be the first stop. They play a very important role, and I don't want to downplay that for any of the general pediatricians in the audience. I think they play a really vital role. But high-risk infant follow-up as a clinical health service has really come to be a standard for the care of high-risk and preterm infants. So much so that it's actually a training requirement for those of our trainees in neonatal perinatal medicine. So all training programs have to have access to some sort of follow-up. So what is it and how does it work? So in a word, there's programs that either have narrow clinical or some that have research goals or both. Like the program I know, there's a wonderful program at Rainbow that Dee Costello-Wilson runs. There's usually a prescribed set of assessments. It's often time limited, so it's usually limited to the first 2, 3, or 5 years of a child's life after leaving the NICU. It's conducted by a small group of professionals typically, and commonly distinct and separate from NICU operations. So there's sort of a disconnect between what we do in the NICU and then what happens after families go home. And there are also differences based on who is actually taken care of and sort of deemed quote unquote high risk for developmental impairment and complex medical problems. And usually these are defined by either gestational age or birth weight ranges, medical diagnoses, and or demographic or social characteristics. This is a nice paper that I cite quite often from 2012. I believe it was out of Cincinnati. And it was a survey of academic programs for high-risk infant follow-up, so specialized programs. And what you'll see here is there's just so much variability in terms of the types of programs that are offered around the country, in terms of who's providing the types of care in those follow-up programs, and the services available, right? What's happening, right? Is it medically oriented, developmentally oriented, or both? And are those programs providing direct services, or is it a model of surveillance and then referral? Sadly, we know that nationally, only about 50% of eligible infants participate in clinical high-risk infant follow-up program, despite it being considered standard of care. The current approach that I've described also has many limitations. Specifically, it systematically leaves behind many groups of children and families. So the moderately and late preterm infants who we know have risk, perhaps a bit less risk than their earlier born peers, but still have risk for health and developmental problems as they grow in age. Term infants with NICU admissions, right, with critical illness often are left behind. There are certain surgical conditions of the newborn period that also lack this type of developmental follow-up. Long gap esophageal atresia is one that I've thought a bit about with my colleagues in Boston, whose the therapeutic intensity at the beginning of life really, I think, would require and necessitate really significant follow-up. And then uncommon genetic disorders. We're doing so much more genetic testing these days for our infants in the NICU, and the ones that are less common but still have some risk of developmental delays associated with them, they don't really have a developmental home to go to after leaving the NICU. Many families are left behind as well, and my mentee, Yarden Freeman, has done a lot of really wonderful work documenting the racial and ethnic inequities, the language inequities, so primary non-English speaking families are less likely to participate in follow-up compared to those speaking English. And then at the community level, he's also noted that very low opportunity communities, people living in such communities, are less likely to participate compared to very high opportunity neighborhoods. This is a study that we published now 4 years ago using Vermont Oxford network data from the ELBW follow-up database. And so there are around 60 programs that contribute data at 2 years for the follow-up of their extremely low birth weight infants. So again, those under 1,000 grams and under 28 weeks gestation. And here you see first the massive amount of variability in terms of follow-up between these different groups or different centers, right? Anywhere from 0 to almost 100% follow-up. The colored dots show you the differential follow-up rates by race and ethnicity. And though it is true that for most centers, white infants and their families are followed or participate in follow-up more often than their counterparts, it's not always true. And so you see that there are a few different centers that for which Black and Hispanic infants are followed more often than their white peers. So this amount of variability just tells us that we don't have equitable participation. The reasons for that we are not quite clear, if it's a referral problem or a follow-up problem, and work is ongoing to try to tease this out. So what does all of this matter, right? This sort of variability and this loss to follow-up. Well, there are significant health services ramifications, I think, though these are not necessarily linked to the lack of follow-up. I will say that. We don't have that information right now. Data are lacking. But we do know that children who are born preterm on low birth weight have a lot of missed opportunities and a lot of missing services. So they're delayed or missing routine vaccinations compared to their term-born peers. There's a lack of medical home and missing subspecialty services, as I noted in the prior studies. Frequent rehospitalizations and missed neurosensory screening. So this is another finding from our New England follow-up network study that we actually found 50% of the extremely low birth weight infants did not have the recommended hearing screening by age 2 years, which I think is a real missed opportunity for finding early hearing loss. There are many, many barriers to early intervention service receipt. And interestingly, a couple of years ago, our colleagues in Australia noted that there are unrecognized and unmet adult physical health problems among very low birth weight infants compared to their normal birth weight peers. So it really seems like there are lifelong, ongoing health services gaps that our patients face. So I'd also like to move in just these next two slides to talk about the impact on the family, because really preterm birth is a whole body condition, right, for the infant, but it's a whole family condition in terms of its impact. So we know that there are psychosocial and mental health impacts for both mothers and fathers. Women and men seem to have different patterns of depressive symptoms, onset and remission, and parental depressive symptoms are linked with NICU stress, which is a really interesting study that was published in JPEDS a few years ago. And parents of preterm infants have more tension, anger, and fatigue. And mothers particularly seem to have more intrusive feelings and hyperarousal, fathers more anger. So though the impact may be present differently between mothers and fathers, it's significant and causes significant morbidity for the parents and the family. There are also differential material resource needs after a child is born early or low birth weight. So we know that children who are born preterm and low birth weight are more likely to be born into families that are impoverished, that have food insecurity, and that experience homelessness. 11% of all live births are paid for by Medicaid, with 9.8% of those being low birth weight. And interestingly, again, this is a recent study that showed that children who are born preterm have lower annual income and lower upward mobility over time, so as adults, compared to their term-born peers. So again, this is a life course issue, right? That preterm birth still has ramifications long into older life. So, I said that I sort of trying to bring together my two worlds of social science and health services research, and I would be remiss if I didn't bring in theory as a trained social and behavioral scientist, so to try to share how I see the world before we think about how can we intervene. So the first is that I'd really like to bring all the pieces together for the child. A lot of my colleagues in neonatology are wonderful, doing some wonderful work, sort of on organ-based and systems-based health and health outcomes. But it really, I think sometimes we lose sight of the fact that this is happening all within one child, right? And recognizing that children with lung disease also often have concomitant attentional problems, that children with brain bleeds or intraventricular hemorrhage and brain injury have problems with school. And how do we bring all of these things together in the individual child? The second piece is really recognizing that the child is living in a context, right? A social context with the family and their home, in a community, and then, of course, in the broader political climate. And all of these things have an impact, sort of bidirectional impacts, on how children grow and develop and learn. And then finally, really bringing together this idea of life course, as I mentioned, right? That preterm birth really is a lifelong condition. It's not a disease. It's not really a diagnosis even, right? It's a state of being. But there are impacts on health and development over time. And so how can we kind of bring all of these things together to really think through, one, laying out sort of a conception of preterm birth and its impacts, and then how do we apply that to intervening, to making meaningful change to help improve outcomes. So here I'd like to bring in this idea of life course health development, and this is not my idea. This is from Neil Halfon and Chris Forrest and others who have really tried to bring together all of these different kinds of models into sort of a greater whole. Bringing together the biomedical models that often are a little bit simplistic, important for understanding perhaps pathways of disease and mechanisms, but really don't tell us very much about how humans are developing in their context. So bringing biomedical models then into the psychosocial world, recognizing that there are hierarchical and dynamic systems at play with multiple determinants, as I sort of showed you in that ecosocial sort of model, with a sort of Brenner-like concentric rings of influence on health and development. And then recognizing that, there's a lot of complexity and that there's relational issues at play between infants and parents, that we need to think about how people might be adaptive and dynamic, and that development is happening over time. And so they've really come up with this idea of life course health development. It's not just life course, but how are we developing health over time? So here I'll hopefully briefly just describe some of the principles of life course health development. I think, if you're interested in social epi theory, I think this is one that's helpful in sort of giving a very broad overview of human development. The first principle is health development, and it's that health development integrates the concepts of health and developmental processes into a unified whole. So recognizing that, sort of bringing together, the physical health and development into one whole in the individual human. Here, of course, thinking about the preterm child. The second is unfolding. So health development unfolds continuously over the lifespan from conception to death and is shaped by prior experiences and environmental interactions. The third is complexity. So health development results from adaptive, multi-level, and reciprocal interactions between individuals and their physical, natural, and social environments. The fourth is timing. Health development is sensitive to the timing and social structure of environmental exposures and experiences. So this really brings together those ideas from traditional life course epi, thinking about sensitive and critical periods of exposure on health and development. The fifth is plasticity, that health development phenotypes are systematically malleable and enabled and constrained by evolution to enhance adaptability to diverse environments. And I think any of us who work in pediatrics, and particularly in newborn medicine and early childhood, know how plasticity plays such an important role in shaping individual health and developmental trajectories. Newborns are unbelievably malleable, and it's amazing how how different trajectories can take shape that might not be expected because of the ability to adapt. The sixth is thriving. So, optimal health development promotes survival, enhances well being, protects against disease, and promotes functioning in physical, behavioral, and social health. And this really gets to what kinds of outcomes are we actually even measuring. And I'll speak about this towards the end of the talk. But thriving really is the ultimate goal. And then seven is harmony. Health development results from the balanced interaction of molecular, physiological, behavioral, cultural, and evolutionary processes. So, really bringing together these ideas into a unified whole. It may sound, I know, a bit much, right? Sort of a theory of everything kind of idea, and I certainly by no means, think that that this is sort of the answer for how we should think about child health and human development. But I do think that it's helpful to bring together all of these different threads into thinking about the impacts of preterm birth or any sort of high risk neonatal condition on outcomes over time, and really gives us some directives about where we might want to focus our energies in terms of investigation and then intervention. So with that as maybe a long prelude, but I'd like to sort of turn our attention to how can we think about using these precepts of life course health development to foster optimal outcomes of preterm birth. This is a figure from a paper that my group published a year or two ago in Pediatric Research, really, no, I'm sorry, in children, apologies, that really lays out ideas about how we can restructure and reframe high-risk infant follow-up for our infants after they leave the NICU using these precepts. So the current approach is outlined on the very far left and column, and in the column next to it, sort of how the life course health development approach might help us think through different types of interventions to optimize outcomes. So the first is that that services tend to be disconnected and they're siloed. There's a lot of fragmentation that I shared with you earlier, and the life course health development approach really is an integrated approach, right? Sort of bringing all of these threads together. The second is intermittent age limited supports, right? That it's bracketed by time, 2, 3, 5 years or so. But that really, there's continuous unfolding of health, and that we need to think about high-risk infant follow-up or preterm follow-up as needing to be really over the life course. And though the same individual might not be providing that, right? People who are focused on early childhood can hand off to later childhood, adolescent health, and of course adult health providers. There still needs to be some thought that prematurity and low birth weight are sort of lifelong conditions. The third is that there's a limited biomedical focus often for follow-up, and that I think perhaps an ecologic approach to address the complexity of health development would be beneficial to really understand the interactions between biomedicine and sort of the environment. The fourth is that there's a rigid clinical schedule sort of to what we do in high-risk and our follow-up program at Boston Children's for many years, and we tried to get away from the sort of regimented, okay, come see us at 6, 12, and 12 months, 15, 24 months, and really to have some more flexibility to it, and really having the timing tailored to the individual needs as opposed to our own schedule that we impose as clinicians. Next, there's an emphasis currently on risk and fatalism regarding outcomes, and I think it's really incumbent upon us to focus on plasticity and adaptation, both in our approach to how we provide the clinical follow-up care, but also in the language we use about outcomes. It's very clear from the literature that preterm birth alone, gestational age, is not destiny, that health and developmental trajectories can take many different courses, and it's up to us to be thoughtful about how we speak about them. Sixth is a focus on clinical goals and avoiding deficits and disabilities, right? That those of us who do clinical follow-up are often very much focused on the clinical, and of course that makes sense. Most of us who provide this care are clinicians or doctors or allied health professionals, and are really keen to avoid these quote-unquote bad outcomes of deficits and disabilities And yet, I think we have an opportunity here to aim for health optimization and for thriving and to really optimizing the outcomes and the potential for that individual child. And the last is contextualization, of course, thinking about harmony with family and community supports. Again, bringing all of these threads together over time. So I'd like to now give some examples, right? So we're in a health services research grand rounds to really take some of those ideas from life course health development and give some examples of some either existing interventions or some proposed ones based on this framework. The first is called e-nurture and touch points, and it really gets at these ideas of unfolding and timing for high-risk infant follow-up. So e-nurture and touch points, it was developed by my colleague, Paige Church, who is a developmental pediatrician and neonatologist who had spent much of her career in Toronto and is now in Boston, and has done incredible work recognizing that we have a real opportunity to broaden the focus of follow-up care, to turn away from strict arbitrary visit cadences, and to really provide developmentally responsive follow-up care that emphasizes what the Canadians have called the F words, which of course is wonderfully provocative for children. And the schema here in this figure is a reframing of the International Classification of Functioning and Disability to really focus on outcomes that we might think of as leading to thriving. So thinking about fitness and bodily and structurally function, so activities that children can do, friends and particularly participating with their friends, family, what are the environmental factors that either promote or inhibit developmental development over time, and then fun, right? What are the personal factors? What is it the child likes to do, and how can we support them? There's a sixth F that they added in a second iteration, which is future, which is really bringing in this idea of time and life course. Here is a table. It's a bit busy for a talk like this, but I want to share what this group has laid out for their e-nurture and sort of touch points approach to high-risk infant follow-up, or preterm follow-up, I should say. And I'll just walk you through it somewhat at a high level. So on the very left, you see the age at the visit, and you do still have to think about the ages, but these are ages that are chronologic, but are also developmentally important and informed. And the second column is the touch point. So what is the sort of the overall goal for that touch point? In the middle, you have the objectives, and then for that visit, what assessments are you using, and then who is supposed to be doing that, right? The clinical team members. So just to walk you through, so at 1 week after discharge, right, that really what's happening in the family, what's the goal is that you're making a place in the family for this new baby. And it's really certainly, geared towards the preterm or high-risk infant, but those of you who have had children of your own or are pediatricians will recognize that this is sort of a typical first visit with a pediatrician, the things that you're doing. The next visit is trying to check in on mental health of the parents, and there are some certain assessments that go along with that. Then thinking about the roles established in family and rituals that are needed, and thinking about family well-being. And then emerging independence for that child, stepping up and out, so how children are to be developing and learning, they're developing their motor skills and social skills, and so forth. And it goes on from there, and you'll see that it goes out into school age, so 7 to 8 years, which is really quite different from the typical approach that most programs here in the U.S. take. And that has been implemented in Canada. I know that there's some attempt now in Boston to do a similar touch points kind of model. From the health services perspective, I will say that having run a clinic, it is a bit harder to let the family lead, right? And the child's developmental needs lead the cadence of visits. It's a lot easier for us to say, okay, come at these different times, and we can schedule you out for those 2 years, right? For those follow-up visits. But I do think there's not only an opportunity to be more developmentally responsive. I think that's important to meet families where they are and meet their needs. The second area from life course health development that I'd like to share is this idea of complexity. The complexity of the health services landscape met with the complexity of the child's needs, and really thinking about how can we integrate care and take a population health management approach to our high-risk infant follow-up, our typical clinical follow-up. So care integration is defined by one of my mentors, Rich Antonelli at Boston Children's. Integrated care is the seamless provision of health services from the perspective of the patient and family across the entire continuum, and is essential to achieving the best health outcomes for every patient. Care coordination is a set of activities and functions that is necessary to create and implement multidisciplinary plan of care in partnership with the patient and their family. So care integration is sort of the higher level system. Care coordination is a set of activities that help us lead to an integrated whole. There are core activities, including high quality handoffs between care team members, care mapping, action planning, and measurement. And I'll go over what each of these kind of means. This is, I think, a really nice figure that lays out the different aspects of integrated care. The first, that it's importantly that it's team-based, and so that team functioning and communication are really hallmarks of an integrated care model. The next is connection to life and community. So both recognizing that there's medical things that need to happen, but also non-medical things that need to happen, and of course thinking about the impact of this child's needs on the family. And then the third is future care planning. So long-term planning with a roadmap, and specifically thinking about time-bound goals. And this, I will say, as a clinician, is something that I don't think we are anywhere near good enough doing, sort of laying out not only what are those goals over the long term, but defining when things should be happening, why, and by whom. So we, a year or two ago, before I moved away from Boston, endeavored on a demonstration project for integrated care for what were deemed high risk, and I use the air quotes, high risk infants. I don't particularly like the term, but it does serve a purpose, right? High risk for what? But we can have a separate conversation about that. But this was a demonstration project to really try to implement aspects of this population health management approach to follow up for infants, young infants with complex needs. It was supported by Mass Health, which is our Medicaid, and the Boston Department of Accountable Care and Clinical Integration at Boston Children's. And it included 3 partnering clinics. So the NICU Growth and Developmental Support Program, or GRADS, the one that I ran, the Center for Healthy Infant Lung Development, or CHILD, which was our chronic lung disease program in pulmonology, and growth and nutrition through gastroenterology. And there were 4 different components to this, and I'll go through them in turn. So the clinic-based population health management was something a bit new for us and for this whole project. Population health, sort of as a broad definition, is that it shifts the focus from caring for patients as they come into the office one after another to proactively managing a practice's patient panel. And what we were able to do with this demonstration project is to actually hire population health managers for each of these 3 clinics. They happen to each be really wonderfully talented nurse practitioners who also provided clinical care in our clinics. But they had a new role. And the role was really made up of 4 different things. So to build a care relationship and navigate subspecialty and primary care, and communicate resources with families, to provide leadership across this multidisciplinary care team, to track progress or challenges along the care plan, and to empower family in the care of their own child. Tall order, right? But they were really wonderful in achieving this. The proactive patient and care tracking is another aspect of this integrated care model. We developed a registry with 5 different track. The first has a really lofty name. It's a locus of integration, or really the anchor. And I'll explain what that means in a moment. The second is connector or co-manager. The third is psychosocial support. The fourth is a little bit of a catch-all bucket for any that didn't fall into the other categories. And the last was traditional consultant and graduated patients. So when they no longer needed our care, say in infant follow-up, we graduated all of our patients at age 3. We could still be sort of in the loop as part of the care team, but not actively following the patients. The locus of integration, or the anchor, was really the lead, that person in this 3-part team that really was taking the lead for the care of that child. And as an example, I'll say for children with really severe chronic lung disease, say who went home on oxygen or a trach vent, that the pulmonologist was really the locus of integration. They were the one who the family looked to for the majority of their care, because that was the pulmonary problem, the respiratory health was really front and center. The rest of us played supporting roles, and that was fine. And I think that was important for each of us to know as clinicians, but also vitally important for the family to know that this is the subspecialist, this is the person that I should talk to first for all of my needs. And just to note that as needs changed over time, the track that the child was in or the family was in would also change, right? So as a child's respiratory health might improve over the first year, they come off oxygen, they're doing really well. But then in that second year, perhaps there's a concern for, say, autism spectrum disorder. Then we, in the developmental follow-up, would become the locus of integration, the anchor, right, the integrator, because then that really became the primary concern, and we needed to be the ones who are going to be help managing those concerns. So it was a dynamic thing. The third piece of this was interprofessional education and collaboration. We had meetups, so bi-weekly discussions with the PHMs, the population health managers, got together to talk about shared patients, and again, sort of talk about care planning and what the needs were and how we could all help. And then there were quarterly interprofessional education conferences with all of us. So not just those PHMs, the population health managers, but the whole teams got together quarterly to do some education, but then also troubleshooting for this pilot project. And then the last was care planning and communication. So really important, right? As I said, this is all about teams and how we as teams function. The integrated care team at Boston Children's and under Dr. Antonelli's leadership developed a validated tool for measuring integrated care for pediatric patients. It's called the PICS, the Pediatric Integrated Care Survey. It's a parent report measure. It's reliable and valid. It's been shown in 2 different studies. We adapted it for NICU and follow-up use, which is the first time it's been used in this population. It's in both English and Spanish. And there are 5 different domains. So access to care, communication with care team members, care goal creation and planning, family impact, and team functioning and quality. We, as part of this project, we deployed the PICS among 88 parents across the 3 programs. And there's some interesting themes, some interesting takeaways from this. The first is that for communication with care team members, 80% said that different teams listened carefully, which was good. Only 55% said that individuals were aware of other team members' advice, which is a critical gap, I think, in terms of the health services landscape. If one set of recommendations from one subspecialist really weren't being transferred to another. In terms of care goal and planning, so 80% of teams discussed big picture goals. Again, I think that's really fantastic. But only 41% of teams made a written care plan with their families. So though we talked about it and maybe put it in our notes, there wasn't really a dedicated care plan that was written out for families. When it comes to family impact, we're doing, I think, less well. So 59% said that they addressed family impact of health decisions for the child. And then only 39% said that teams were addressing additional family stressors, so other things that were coming into play that perhaps weren't medically relevant or coming from the medical care for that individual child, but were adding stress to the family and perhaps impacting the ability to follow through on care team recommendations. This is a tool that we developed that's called the Action Grid to help with this written care plan gap. It looks very simple, and I will admit I think it is quite simple, and yet it has some real magic in it. So it's really just a table that you can create yourself that has the goal, right? The goal of care, the action, the person, the provider, who, when, right? So thinking about that time bound aspect, right? When is this supposed to happen? And then contingency planning. What happens if that plan doesn't really come through? So for a typical child, and this is actually old, I need to update this, right? This is when we were giving Synagis. So the goal there would be RSV prevention, right? So giving Synagis, which happened to be an injection that children needed to have monthly. The who is primary care. For us, that was who was administering it. When, right, that was RSV season. And then the contingency plan, right? So if you can't do this, if the PCP didn't do it, call us, NICU grads, and we'll step in and figure out how to do that. And you see so on and so forth. Importantly, this is done in in collaboration with the family. So I don't have here an example of a family-directed goal, but they certainly have their own goals, and we should incorporate that into these action grids and these care plans to be able to then meet their goals for homegoing and then iteratively. The idea was to use this at the time of discharge and then to update it every time we saw the family. And we are in the process of trying to digitize this and put this into our medical record. The last tool is this care coordination management tool, the CCMT, which maybe is a little less snazzy, right? Because it's not patient facing, but I think critically important to what we do as clinicians and the health services that we provide. And the idea here is to be able to document all of the care coordination that we do, to measure the activities and the time taken to actually help support families outside of the clinic visit itself, right? So any clinicians who are here listening know that so much of our time in the outpatient world is spent responding to either phone calls or usually inboxes in our EMR, emails, pages, text messages, to help families get what they need. And yet that time is not reimbursed, right? It's not recorded. It's not reimbursed. And it takes away from a lot of the other work we need to do. So this is a tool that can be used to outline the needs, the activity, the outcome. So what happened, right? Did you refill a med? Did you have a child go to the ED? Did you keep a child from going to the ED? Averting an unnecessary visit of some sort. What is the time that you spent doing that, and who was it, right? Was it a doctor? Was it a nurse, a social worker, etc.? And these kinds of data are actually being used in centers that are using it to track the amount of time, to track outcomes, but then also to advocate with hospital leadership for resources, right? To help support this kind of important work that we're all doing that's really under the radar. And so this has been transformed into a program. This was a successful pilot. And now that Mass Health has sort of picked it up with sort of a broader program for children. I've sort of lost touch a little bit with where this is going. I know that it was supposed to be implemented last summer. So I'm eager to hear about how things are going with these next steps. So the last piece, and before we open it up, and please, if I'm running short on time, please let me know. Just give me a wave. I'm happy to wrap up. But I wanted to talk a bit about thriving in harmony. So, and this idea of measuring what counts. So, often in our clinical follow-up, we're sort of using some sort of rubric, either written out, a checklist, or something in our head, right? That the list of things that we feel like we need to accomplish at each visit. And again, any clinician out there knows that that's part of what we need to do, right? If a child is coming in for sort of a routinized type of visit, there needs to be a plan. And I think that's important, and I don't want to sort of discount that. And yet, we've been told by families that those aren't necessarily the things that they care about, right? That making sure that we go through each of the items on the Bailey, developmental test, for example. A lot of families have told us either we know my kid is doing well, or I know my child is delayed. I don't need you to tell me that. I would like you to help me with other things. So how can we sort of shift our mindset into thinking about how can we measure what really matters? So here I'll share with you on the left a study from a few years ago from the Canadian Neonatal Network, where they actually asked families, what are the things that you care about? And, it broke down into these different overlapping topics. By and large was development, so language and communication, behavior and emotional health, motor developmental movements, and cognitive and learning skills. So these things are certainly important to families and things that we use developmental tests for, but not necessarily communicated in the way that families are looking for, like translating those test scores into actual applied outcomes. The second is respiratory health and fragility, and certainly a lot of concerns about how to keep their child safe, particularly during cold and flu season. And then nutrition, feeding, and growth were important. And I certainly, having done clinical follow-up for many years, know that, this all resonates, that these are the questions that families often come in asking about, but they're not ones that we actually all have really great tests for. On the right is a figure from a paper that is under review, a qualitative study that we did with families, providers of clinical follow-up care, and sort of content experts in the field, and noted again that there were certainly things that families and providers thought we were doing well, but there were certainly gaps, particularly when it came to patient-level care factors, and that we weren't really supporting social determinants of health. We weren't really thinking of and measuring family mental health and well-being well enough. And there was sort of a lack of a focus on sort of longitudinal transition and what they could expect from their family or from their child over time, and what supports they needed to have in place as that child graduated from our program and moved into the developmental care with the developmental pediatricians and into the school system. And this is a wonderful cartoon from a recent paper on the language you use and how we can be sensitive to families' needs, both in the NICU and after. And this is what the authors called sort of the cauldron of uncertainty, and so much emotion goes into families' experience when they're in the NICU and when they're leaving, and that these types of emotional concerns and stressor concerns are really left out of our follow-up visits, right? I mean, they come to the fore in many different ways, but they're not really I would say, typically addressed in a forthrightly way, right? They come to the surface, but we're not really, I think, doing our due diligence to make sure that we're addressing them and normalizing the experience that families are having. We do a really good job of measuring diagnoses and symptoms and giving families test scores at our follow-up visits. But we're really not so good about measuring activities of daily living, independence, participation, and stamina, which is a really interesting kind of idea. And some of these come from pediatrics literature, but then also some concepts from the gerontology literature, actually, stamina and ideas of frailty, right? It's like how can we participate? How are we doing our daily living activities? How can we bring those things into our visits, both with good quality measures, but then also interventions that we can then relay to families. And thinking about overall child health, how can we better measure it? So this is, I think, a really wonderful definition of child health. It's the extent to which individual children or groups of children are able or enabled to develop and realize their potential, satisfy their needs, and develop the capacities that allow them to interact successfully with their biological, physical, and social environments. There are some measures that have been put forth. There's this idea of positive health that came about several years ago. I'd say I'm not. I don't think this one quite hits the mark. It's really sort of an inverse of diagnosis count. So positive health sort of defined as the lack of diagnoses, which I don't think quite gets us there. There are measures of health-related quality of life for pediatric populations, and I think this really gets to some of the heart of it. There's a functional status and disability in pediatrics, the PD, which I haven't used, but I'm curious to use in some of my work going forward to give us some sense of how children are actually functioning in their own environment. And then there are a number of measures on family impact, and this one, the IFS, is just one example. That's actually several decades old now, but still elicits the impact of a child's complex or chronic illness on family life. This is a nice recent review of different frameworks and measures of maybe what we might conceptualize as thriving. So the first is, like strong minds and body, positive identity and self-worth, caring families and relationships, vibrant communities, health environments, safety, fun, and happiness, and racial justice, equity, inclusion, which I think is a really nice addition, because how can we, of course, thrive as individuals or in our families if we're feeling we're being treated inequitably and unjustly. So you see that there are a number of frameworks and a number of measures, yet I really haven't seen these used in research on infant follow-up. They're certainly not routinely used in research settings like the Neonatal Research Network that both of our institutions are a part of, nor are they used typically in clinical follow-up to really understand how children are doing in context. A few things that are in the works before I wrap up and get to discussion. I'm part of what's called the Life Course Translational Research Network, which is an MCHB funded and supported sort of incubator for life course work. It's based at UCLA, and I am privileged to help run the Success After Prematurity node. So there are 9 different sort of focus groups, and the prematurity node is one of them. We have a few different pilot studies going right now. One is an app development and implementation for navigation and coordination, so using sort of a virtual assistant to help with some of those complexity issues. We're developing a web-based mental health education modules for NICU parents during the hospital stay and afterwards with our NICU psychologist here at Stanford. And then in coordination with the Thriving Center at Georgetown, trying to develop a measure of thriving, which of course is a really difficult thing because what that means is so personally dependent, right? I mean, if you asked each of you what it meant to thrive, I think I would get as many answers as there are people here on this call. And then in collaboration with the California Department of Health, here at Stanford, we're engaging on an environmental scan for medical home participation for young children with special healthcare needs. So it's known, again, that, as I said, medical homes are not actually being utilized, and it's unclear why, and yet they are a national measure of healthcare quality for pediatric care. So we are endeavoring through our network of high-risk infant follow-up programs through our collaborative here in California to really understand parents' understanding of medical homes and why they may or may not be engaged, and then to develop community-based interventions to increase participation among California youth. So with that, I'll just bring us back to the schema, sort of trying to bring each of these precepts and concepts of life course health development to really focusing on making improvements to the care we provide to our preterm infants and other at-risk infants as they leave the NICU and go off into their homes and communities and hopefully develop along optimal health trajectories and thrive. So with that, hopefully we've accomplished our learning objectives. I'll say thank you, and I'm eager to hear your questions and comments and engage in discussion.
Thank you, Jonathan, for a very comprehensive talk and many novel insights to help us reframe how we think about long-term follow-up of high-risk infants. So we have a question from Andrew Garmer, and the point is this actually a call for more investment in primary care if the ultimate goal is thriving rather than just on applying this framework to at-risk infants?
Yes, in short answer, yes. I think it would be wonderful if the family center medical home model could really truly be the home for these higher risk kind of infants and their families. I know there's actually a wonderful health services researcher at Hopkins, um, Brandon Smith, who is a general pediatrician, but really interested in this patient population and really interested in making investments. And exactly as the question asked, how do we build a system of primary care that can really meet most of these needs? So certainly, I'm eager to see what he develops and others.
Thank you. We have another question here, and again, this keeps on coming back again and again whenever we discuss about high risk follow up. The question around sustainability and scalability, and that's something that we hear all the time. So, what are your thoughts on sustaining and scaling some of these follow up programs and the models you have?
Yeah, yeah, that's so important. Again, having run a follow up program, right? That it's always a tension between what the needs are for the families and what the resources are that we're given. And ICT is on the call here too. Like we all know that we work on a shoestring. It's never supported how I think it ought to be. Um, and the answer I don't think can always just be throw more resources, right? I think we need to think about how do we use our resources more efficiently, and that's where I think some of this value-based care that I didn't really get into, but I really think is important. And the care integration, I think, might be one step. If we're all talking to each other and improve the communication among the different care team members, we can, I would hope, reduce inefficiencies by limiting, duplicative services, right? Or having fewer unmet needs that then sort of lead to more problems down the line. Having access to somebody who can help determine, okay, triage, do you need to go to the ED? Can we keep you at home? A lot of families just don't have access. I've actually spent the last year or two really thinking about what's happening in resource limited settings, not necessarily urban settings. I think urban settings, certainly there are their own challenges, but a lot of these programs are happening in academic centers, which are urban areas. So we have our own work to do. But what's happening in rural settings and sort of the frontier land? I had the opportunity to go to Montana 2 years ago, and learn about the work being done there. And the pediatricians are doing an amazing job, right? They don't have when the pulmonologist only comes to the state twice a year, but how can we improve access in leverage digital health and technology, right, to help with those efficiencies? So those are just a few ideas I have.
Thank you. We are a few minutes over time, but I'll
Oh,
just
sorry.
ask two very quick question. And one is, we what do you see as the role of AI-based integration in increasing efficiency and even effectiveness of care? And that's one. And my next question is more of a philosophical in a way. Why do we think there is so little progress over the last 3 decades in terms of developing new models of care? I know very few sites that have even gone that path of innovation or really testing different models of things. So very quick.
Yeah, so I think one in a word, AI I think will be helpful in the little that I know about it. I'm learning a lot. Here being in the very heart of Silicon Valley, I have a fellow mentee who's really interested in the use of technology and AI and how we can actually use that for follow up. So I think it will be very helpful. I'm not exactly sure how. It's a powerful tool. How can it help us with communication? Can it help us with the app development, right? And just trying to have sort of virtual or digital navigation, linking to community resources, right? I think can be really helpful. The resource lists that our social workers have, which are wonderful and comprehensive, but they get outdated every month almost, right? Because right, so that kind of thing I think can be really important. The philosophical question, I think I've spent a lot of time thinking about, and I think this is such a small area of pediatrics, which is in itself such a small area of healthcare, as we know, right, in this country and in the world. And my sense is that follow up came out of a sort of a research and QI kind of place where good-hearted neonatologists wanted to know how did these kids do and how can we improve the NICU care. And I don't think people have really thought about it as a health service in and of itself. And I think that's, to me, the big limiting factor, right? Into why we haven't innovated. It's because I don't think we're thinking about it in that way. Of course, those of us who are involved in it do. I mean, we know that we're doing clinical service, we're doing care, providing care. But I don't think we necessarily have taken that heart. I don't think our neonatology community as a whole has recognized that. So that I don't think we've actually brought all that the health services research methods and thinking to making improvements and making headway.
Thank you. That was fantastic. And mm, thanks again for joining us and for all of your insights. Please let us know when you're back in Cleveland area. It would be great to have you in person. Thanks to all the attendees for joining us this morning, and we'll see you all next month. Thanks. Bye-bye.